So our third and last speaker is going to be Dr. Alfred Banya. Please pay attention because this is a pastoral, aspect of looking at the corona vaccine and taking a pathway towards the vaccination. Dr. Banya is our son, of course, in the diaspora here in London. He is a deacon, he's a Catholic deacon in a Catholic church and head of chaplaincy at King's College Hospital, National Health Trust in London, here in United Kingdom. Dr. Banya obtained a degree in medical parasitology from London School of Hygiene and Tropical Medicine. And he went back and taught actually parasitology at Makerere University. He came back to United Kingdom and obtained a doctorate degree in healthcare research from the Lancaster University. He also holds a degree in healthcare ethics, theology, and care in general. Dr. Banya worked with the South London Borough as Assistant Director of Public Health before he retired to take up a pastoral ministry as a deacon. Our next speaker, ladies and gentlemen, Dr. Alfred Banya.
Thank you very much, Mr. Chairman. Can I share my screen now?
Yes.
Are you able to see?
Yes, go ahead, Dr. Banya.
Yeah, the first slide seems to have been corrupted, but anyway, thank you very much, Mr. Chairman. Yes, I'm delighted to join you in this discussion on attitudes among ethnic minority towards COVID vaccine. And it's good to share it with participants from here in the diaspora and also those who may have tuned in from elsewhere. It's very much a UK context, but I hope that it will, some of the issues may be relevant to other places. I'm presenting this in a personal capacity, so that's really the disclaimer that I would like to give. Although I'll be drawing from my experience as a healthcare chaplain and also in terms of my previous experience elsewhere, it is in a personal capacity that I'm presenting this. So I own any inaccuracies or anything else that arises from this. Just to, as I've put up the aim here, I would like to share really my perspective on the impact of coronavirus on the UK minority. And when we say ethnic minority, I know it's a contested term when we talk about BAME, Black and ethnic minority, and so on. We are talking about Black Africans, Black Asians, and Black Caribbeans. And also just, I know Professor has already alluded to some of the reasons for poor uptake, but I would like to give it from my own perspective in terms of experience interacting with various staff in the NHS and various community members and various people of faith. And then go and share my own personal experience of vaccination in terms of my route to vaccination. You may ask, so what? I hope that out of sharing this, I will enable you to reflect a little more deeply on any decisions you may take, whether to get the COVID-19 vaccine or not. And because I'm not here to force you to do that, but I hope by sharing, you will be able to think a little bit more before you make up your mind. And also to encourage a more responsible sharing of information in the community about COVID-19 vaccination. Professor has already alluded to the kind of misinformation that pervades our social media network. And also to increase awareness or responsibilities for each other, irrespective of nationality, national, ethnic, or religious background. Although we are talking about Black and ethnic minority, I mean, if there are any people of other background who are here, we share responsibility for each other. So some of this would be useful information for them also to take on board. So my presentation will cover a perspective on the impact of COVID, go through some of the underlying reasons for poor uptake, and some of the moral and ethical concerns and the response of some of the faith groups to this. And then I'll reflect on my personal experience along the vaccination route. So the impact of COVID-19 on ethnic minority. I mean, I think Dr. Churchill made very good analysis and background. And these are some of the debates, because I was on Radio 4 in the first wave of COVID, and we had an in-depth discussion about this. The discussions often around, is it biological factors or is it social and structural factors? And I'm glad that Dr. Onen was able to bring forth the proposition that it's, you know, it's a bit of both. You know, our Black people having that predisposition to cardiovascular disease and diabetes and other conditions kind of predisposes them to that. But there are also some social factors in terms of social inequality and income inequality that, you know, bear relevance to this. For instance, in the first wave, this was an article that came out in the Guardian newspaper 9 months ago. It talks about Black and ethnic minority groups being hit harder by COVID than white people, which a research undertaken showed that most of the people who are critically ill patients came from that group. And in fact, in Dr. Nen's presentation, he pointed out that deaths over 60 or over, about that figure, of staff who died were from the Black and ethnic minority. NHS staff who died were from the Black and ethnic minority. And although they formed, you know, I think it's a little higher than 20%, but not, you know, it's around 20 to 30% of the NHS workforce, and yet they were disproportionately impacted upon. This is another article which came out in one of the newspapers called The Tablet, which is a faith newspaper, which went into some of the racial inequality that they felt underpinned the reason why there was disproportionate impact of COVID on Black and ethnic minorities. I think the structural factors are important because we can talk about the biological factors, which then kind of puts the blame on the individual by saying, well, you are born that way, that's why, you know, you are disproportionately affected, therefore we can't do anything. But, you know, that's besides the point. There are some structural factors that impact on the higher risk that Black people face. Part of my pastoral role is about looking after not just the welfare of patients, but also the welfare of staff in the NHS. And one of the things that we keep an eye on is what's called the NHS Workforce Race Equality Standard, which is an annual survey that gets responses from staff in terms of their working conditions. And the latest one we have is from 2019, where the data showed that the percentage of Black workers in the NHS trust in England who reported personally experiencing discrimination at work from a manager or a leader of a team and other colleagues was 15.3% compared to under half that figure, which is 6.4% for white people. Why is this significant? It is significant because if you have a working condition where individuals are reluctant, are discriminated against by their team leaders, they are then more reluctant to complain about their working conditions. So that is why there was a lot of controversy about availability of personal protective equipment for staff. So when I was walking to work one day, I saw this poster, this banner on the left, which says, "NHS, you are golden," praising the NHS staff. And then a few weeks later, when the debate around availability of personal protective equipment became quite acute, these posters about unfair treatment of staff in terms of not having the proper personal protective equipment started coming up. This is just an example. The one on the right is just an example of one of those posters that was put up, which says, "Fund the NHS PPE for all hospital staff, save lives." Basically, because a lot of we have got a lot of overseas trained nurses recruited, for example, from Southeast Asia, who are brought into the NHS. They don't speak up for themselves. And if they're asked to go to a particular ward or workplace, they'll go there and work long hours. And if proper equipment are not available, they are very reluctant to complain. But as chaplains, we hear these concerns, and they tell us that, look, I don't want to complain because I don't want to be seen as a troublemaker, and therefore these issues don't get addressed. So advocacy, the importance of advocacy and solidarity with those individuals is very important. Speaking up or advocating on their behalf. And that's why I'm saying if there are people of non-BAME background who are listening in, I think it is just a human responsibility to support those who, for any reason, may not be able to speak up for themselves. That's why I'm saying listening to such marginalized groups and being in solidarity with them by demonstrating that we are each responsible for each other's welfare as human beings, as the human race, irrespective of our background, is quite important. But then you say, if that's the case, if there's this high this impact, disproportionate impact, why then the COVID-19 vaccine hesitancy, this reluctance amongst the same group that are disproportionately affected, are now not coming forward to take the vaccine? And it's not just in the general population, even amongst NHS staff. Remember what Dr. Nen put up, where you had 60% died, yet they only form 20% or so of the workforce, and yet when offered the vaccine, they are not taking it up. So these are quite serious questions, and I think these are some of the possible factors. The possible factors which keeps on coming up when I talk to individuals regarding. There is general lack of trust in a white-dominated Western system because of Black people's historical experience. I think, for example, a lot of the Black and ethnic minority who are Black Caribbeans very much talk about the history of slavery. And to some extent, I hear also talk about colonialism and exploitation, and the fact that it is a system that cannot be trusted because it has done things which it hasn't even apologized for or given provided reparation for. And then again, there's the Tuskegee syphilis experiment, I think, which happened in the 1930s and took about 30 years, where Black people were recruited, and without their consent, syphilis experiment was carried out on them. And they were only told that they've been recruited into a program to look at how to deal with treating what they call bad blood, and they were promised as a kind of reward, treatment and so on. But the treatment was, even when penicillin became available, the proper treatment was not provided, was not provided for them. And in fact, the whole thing was investigated, and it was discovered as having been carried out unethically. But this is after so many of them had died because of the disease. And in this case, anyway, some reparation was given. They were given payment as well as access to medical care for life. The last one, I think, died. The last person who was part of that experiment, I think, died in 2014. And I think there are 11 surviving offsprings of those people who are part of that experiment. But this is something that plays into the minds of people in terms of the unfair treatment and discriminatory practice that a white-dominated system unleashes on Black people. So there is that community trauma that's still there, which also forms the backdrop of the mistrust in terms of developments such as the COVID vaccine. And I mentioned about vaccine hesitancy amongst Black and ethnic minority NHS staff. What's emerging is that there are fewer Black and minority ethnic NHS staff who are coming forward to get vaccinated. In some hospitals, only 25% of Black staff have come forward compared to 50%. I'll give you another breakdown. I haven't named the hospitals here. These are hospitals in London, and in one hospital, they've reported that Black African among the Black and ethnic minorities, Black African and Black Caribbean staff who show the highest vaccine hesitancy. There is some, but the Filipino staff as well as showing lowest uptake for some reason. I don't know if there are some, most of them are nurses who are recruited from overseas. A lot of them also have strong religious affiliation, quite a significant number Roman Catholics, but there may be some reasons behind that. So I'll come to the religious aspect later. And in Hospital B, again, very low take-up from Black staff, 24%. The Asian Asian uptake is slightly higher, and the white staff uptake is up to 60%. And Hospital C, again, Black African and Black Caribbean is very low. Sorry, the Hospital B, I can't see it properly because, let me just minimize. Yeah. So anyway, you have seen the trend of the statistics. some of the contributing factors to vaccine hesitancy, from my experience, which I think Professor Kot Umar has covered, there are those ethical concerns about the harm. The questions about, has it been tested for long enough? What are the side effects really known? And this has been exacerbated by the kind of misinformation misinformation as well as disinformation that goes on social media, especially I've seen it on our community forums where one person dies because of something that's associated with the vaccine, and then you get a clip, circulating everywhere, but nothing is circulated about those many who have actually taken the vaccine and been okay. So most of the circulated messages has been about some of those serious though they are, things like the side effects, but they are not put in proportion to those aspects which have not resulted into serious outcomes. And there are moral and religious concerns as well. There is the alleged use of products from pigs, which has been circulating. Obviously with our Jewish colleagues and with our Muslim colleagues, this is a real matter of concern. But there is no evidence that this is the case, because there is assurance that there are no animal products. It's not just a religious concern. There are those who are vegans who do not want any animal product to enter their bodies. So that's not a religious concern. It's a philosophical and lifestyle concern, which are equally important. So these are some of the issues that form the backdrop of vaccine hesitancy. And in terms of religious concerns, there is the concern about the use of aborted tissue. This is related to the Pfizer vaccine, where a lot of work, preliminary work was done using fetal tissue, sourced from fetal tissue that came out of tissue that came out of a aborted fetus in 1983. So obviously, in terms of those who are against abortion, this is a real issue. But then, against this background of misinformation, the main faith groups in the UK have publicly declared their support for the COVID-19 vaccination. The Muslim position, we've got the British Islamic Medical Association and the British Muslim Council, who have stated the following, and I'll read it out. This was specifically with regards to the Pfizer vaccine. They say individuals should take this COVID-19 vaccine on the advice of their medical practitioners, following informed consent. So they're saying that they need to really balance the evidence. This is to protect these specific groups from probable and considerable risk of harm from COVID infection, which is likely to be greater. This is important. They say the risk and harm from COVID infection is likely to be greater than any harm from taking this vaccine. So there is the ethical argument of, of harm, balancing out the risk. And of course, they say they will continue to review this recommendation based on available evidence. The Christian churches For example, this is a group of churches in South London, came up with another supporting statement saying the ecumenical partnership of churches together in South London. They know, they say that we know that some people have concerns and fears about COVID vaccination. So they're not dismissing the concerns. They say they do not underestimate these concerns, but they're relying on current reliable scientific advice that the vaccine offers the best way to control the pandemic and to help to save lives. And they conclude by saying each of our Christian traditions allows for the vaccine to be received for these purposes. So these Christian leaders have considered this, and in terms of church teaching in support of this. So the argument that faith groups are against this does not really hold. So that's misinformation if it's being circulated. I'm not saying that all the faith leaders share this. There may be some other individual denominations who may have their own position, but broadly this is the position. And this is a picture of the church leaders and who signed that statement, and also signed this pledge. The ones who have received the vaccine are saying, they've, at the bottom you'll see, at the bottom it says, this one says vaccine received. This one says we'll accept of the vaccine if offered. This one will says we'll accept if we offer. Those who have already received the vaccine have signed up to it. So there is that support from faith, from faith leaders broadly. Specifically, the Catholic Church position. I'm returning to this because it addresses the issue of the use of aborted tissue. So this is really in relation to the AstraZeneca. Yes, I don't know if I said it was the Pfizer, but it's the AstraZeneca vaccine, whose development seemed to have some link with the use of aborted tissue in previous, in earlier developments. So they say that the AstraZeneca vaccine, since it has been developed from cell lines originating from cells of an aborted fetus in 1983, this has raised some concerns. So there is what's called the Congregation of the Doctrine of the Faith and the Pontifical Academy of Life, who study these issues. So they have expressed the view that one may, in good conscience and for a grave reason, receive a vaccine sourced in this way, provided that there is sufficient moral distance between the present administration of the vaccine and the original wrongful action. In the COVID-19 pandemic, we judge that this grave reason exists and that one does not sin by receiving the vaccine. In other words, the use of the original development, which happened far back from 1983, of trying to engineer the vaccine, has got some distance with the vaccine that has already been developed, in as much as that act of abortion, use of abortive tissue, is not justified, is not endorsed by the church. What has come out of it, and the fact that the vaccine itself doesn't contain the fetal tissue itself, and has resulted into development of something that would end up saving lives. The balance, the moral balance is that it's better to take that than to completely say no to it if the end result is about saving more lives. So that's the argument and judgment they've given. But what they've said, though, is that they're not forcing people to take it. They say that each Catholic must educate his or her own conscience on this matter and decide what to do, also bearing in mind that a vaccine must be safe, effective, and universally available, especially to the poor of the world. And it says Catholics may in good conscience receive any of these vaccines for the good of others and themselves. And in good conscience, they may also refuse a particular vaccine. But then if you refuse it, you need to continue to have a duty to protect others, from infection. So they've thrown it back to the individual to make that informed choice. So for me, having seen all that, it informed my own personal journey along the vaccination route. The context for me is that as a chaplain in a hospital setting, I face daily risks because I'm there in a setting where there are large numbers of patients who may, who are definitely COVID positive, and also working with colleagues that may have been in contact with them. So there's that setting in terms of the work setting, but also I have those risks, some of those risks that Dr. Nen talked about. So I needed to consider those as well. So as you can see from this picture I've put, the chaplaincy role now involves having to wear all these things, obviously the mask, the face shield, and so on. When you go to a patient, sometimes they wonder whether you're a chaplain or, or a doctor and so on, because in this one, I did not put on the gown, but when you put on the gown, you're all covered, you're all covered up. So, that's another challenge. That's another discussion anyway. And so the setting within the hospital itself varies. You may be called to a neonatal intensive care unit where the risk is slightly lower, or you may be called to an intensive care unit where the risk is higher, where you need to wear, the complete PPE because of the aerosols, the droplets that are generated from patients who are intubated. And when you go in, you can't just stand a distance from the patient. You need to be close to the patient. So you need to be fit tested with not the surgical mask, but a different, higher grade mask that fits you. And some of these masks are not designed to fit the faces of some of us as Black people in terms of the nose shape and so on. So many of us actually fail the fit test and are sometimes unable to go in. But with the more better developed ones now, they fit a lot better than the earlier ones. So the earlier ones were not fitting many face shapes like mine as the more recent ones. So you may be called to a general ward where the risk is slightly lower, but you still need to be careful. So those are the kind of varied risks. So I needed to take account in making a decision. I needed to take account of those risks, that I'm taking. And of course, I needed to take account of my family context. Now, the picture on the left is myself and my granddaughter. In the middle is myself with extended family in Uganda, and then on the right is myself and and my wife, at home. So if I just said I'm not going to consider this and dismiss something that has a chance of protecting me, and I end up dying, what would the impact be on all these people? So those are some of the thoughts that went into my decision making. So the consideration was ethical in terms of balancing the degree of risk to myself and others if I did not take the vaccine. faith and morals. I've already covered the Catholic teaching because being a Catholic, obviously the issue of abortion, using abortive tissue was a matter that I had to consider. The use of a messenger RNA-based vaccine was also something I needed to consider. But one phrase that stuck in my mind was that advice from the Pontifical Academy, which says, one may in good conscience receive any of the vaccines for the good of others and themselves. So that is really formed the basis of me pinning down the final decision that I made. So my preference, although the Oxford vaccine, the AstraZeneca vaccine, has got this link with aborted tissues, I would have preferred it basically because it's based on a technology that has already been used before in terms of producing the flu vaccine, which I already take anyway. So I thought, if I'm able to take the flu vaccine, why should I take a vaccine based on a similar? So that's why my preference would have been for that. But my workplace offered the Pfizer vaccine, and I went for it anyway. The process was quick on the day, but the preliminary information given when I went, the leaflet with the things that you needed to read was so much in scientific jargon that I really wondered for lay people who would not be able to understand that. I will return to that in my next slides. I experienced very minimum side effects, the swelling at the injection site, muscle aches for about 3 to 4 days and so on. Not so much fever, but so the side effects themselves were not that serious. So just to go through to give an idea of what happens at the vaccination setting. When I went, my temperature was taken so that I wasn't, it's determined that I wasn't developing a fever or anything like that. My details, my name, my GP checked. And this might be another issue for Black and ethnic minority people who may not necessarily be registered with GPs. In the past, those who are here who are undocumented migrants who may not have papers may have reluctance to register with GPs. So that may be a barrier for them getting the vaccine. But as you know, government has announced that the vaccine will be available to everybody, whether you are here legally or illegally. So that shouldn't be a problem. And GPs have been asked to register people so that they can, people can take that vaccine. So if there's that myth, then I think, that needs also to be debunked, because you can register with a GP and so that you have access, to the vaccine. So a brief medical history of recent sickness and of allergic reaction is taken. Information is about the vaccine is then given so that you read while you wait to be vaccinated. And then after vaccination, you're given a card with which has the batch, the vaccine batch number, so that if anything adverse happens, they can trace which batch you had. And then there's space on the card to record the date for your second dose. And then you wait in the if once vaccinated, you wait in the recovery area for 15 minutes. Someone keeps on coming, checking on you, just to ensure that you don't develop an adverse reaction. But I found the leaflet a bit worrying, because especially information asking if you are allergic to some of the contents for you to be aware of. So there is a bit in the leaflet which I've reproduced here. It says, if you are allergic to the active substance or any of the other ingredients of this medicine listed in section 6, signs of an allergic reaction may include itchy skin, rash, shortness of breath, swelling of the face and tongue. Contact your doctor or healthcare professional. So you're already there, you're given this. It's a section in a 4-page A4 material. It's a bit overwhelming. And the list of ingredients in section 6 are these. It has, so for a lay person, who would know that they are allergic to polyethylene glycol /macrogol? Who knows that they're allergic to 4-hydroxybutyl? Who knows that they're allergic to potassium chloride, potassium dihydrogen phosphate, sodium chloride, disodium hydrogen phosphate dihydrate, and so on and so on. So this is what I thought. This is a list that was given. Are you allergic to this? I said, well, I know that, well, that's not the question, but you are meant to go through this. And then if you're allergic to it, then just remove yourself and go and consult your doctor. I thought that was a bit much. I don't know if in other places, I don't know whether it's just in where I went that this is given. I would like to hear from people who have gone to other places whether this is the case. If we are to feed back to those responsible for vaccination, I think it's an issue that we need to raise. The postscript is soon after getting vaccinated, 10 days after that, actually, I fell ill. And then I went and tested positive with COVID. So looking back, I must have got the infection 4 to 5 days after the vaccination. And the symptoms I had, the COVID symptoms I had were cough, sore throat, upset stomach. But surprisingly, I didn't have any high temperature because I bought a thermometer and was monitoring my temperature myself. And then I quickly lost my sense of taste and smell. These symptoms surprisingly subsided after 5 to 6 days, although some of the aches took a bit longer. And I'm now perfectly well. In my team, 3 of us tested positive. A colleague that I work closely with was admitted to intensive care, intubated, very critical. Is still in hospital. He did not get. He was still deciding whether to get the vaccine or not. So the question I leave you with: could it have been more serious in me if I had not got the vaccine? I don't know. Even though I think I got the infection just a few days following the vaccination, and perhaps the antibodies would not have built up high enough. They say that it does build up between 10 to, 12 to 2 weeks after vaccination. But it's possible that maybe I had some level of immunity developing already that mopped up the virus particles. I'm not sure, but there you are. But my conclusion really in terms of this presentation is that rather than falling prey to conspiracy theories and misinformation, each person must really reflect seriously and make an informed decision whether to get the COVID-19 vaccine or not. Secondly, I think we need to be, this is quite serious, we need to be responsible and not be the source of spreading misinformation about COVID-19 itself and vaccination in our community. Our community is already traumatized enough with other experiences. So I don't think we should be agents of adding more experience based on information that we are not sure of. Instead, we should be working for their welfare. And then lastly, we need to be mindful of our safety and that of others. at work and in public places, irrespective of our background. It goes back to what I mentioned about advocating for those who may not speak up. If you know that somebody here is, for instance, an unregistered resident without papers and is afraid of getting the vaccine because they have no registration with a GP, then you can advocate on their behalf, and support them, let them register so that they get, they get the vaccine. So thank you very much. This is what I have prepared for you. So I hope you found it useful. Thank you, Chair.
Thank you very much indeed, Alfred. Now you have had the pastoral aspect of everything. I think we can now open it for maybe one or two questions. James, unmute your microphone. Yes, James, how are we for time?
Well, I think we already, it is past time.
Yes.
I think there may be one or two things that we perhaps we will need. I was just thinking of releasing a survey, which it would take less than 2 to 3 minutes for people to answer. So we could, I think Diaspora could put those questions while I actually try to put the survey on the chat so that people can participate.
Okay, Diaspora, probably you maybe one or two questions, but I mean, the people should not be disappointed because the question you can either type in the chat. All the questions that are typed in the chat will be answered by the specific people you have directed this question to, or generally by the panel. And secondly, if you think of the question later on, after we have already closed, you can still go to our website where there's question and answer and ask your question, a considered question there. We will answer those questions as well, because we want to make this as educational and accessible as possible. So Diaspora, can you give maybe one burning question?
Okay, we want the question relating to the vaccine rather than the diabetes, hypertension. Okay.
No, this is now vaccine.
Okay, let me read out these 3 questions. Okay, the first one, given what we know now to be the public attitude towards COVID-19 vaccine, could you please help explain to us, Joe public, in simple terms, what RNA is and how should it help in our personal decision making in choosing what type of vaccine to accept, please?
Now, okay, that is now going to be scientific, which is is going to be out of reach for Alfred, and maybe Professor.
I think moderator person to answer that.
Yeah, I will. I mean, let me first go. Let me first go through the panel.
Before you answer,
yeah,
can I give, in my own journey to vaccination, what my lay understanding of that was?
Yes, that's a good idea.
That made me not fear having messenger RNA in me, in lay terms, because from the information that I got my understanding was that messenger RNA was that element of the genetic material that would enable the production of a protein that would imitate a viral protein and therefore elicit a reaction in your body that would create, antibodies that would protect you against the real virus once it comes. And from what I read, that messenger RNA is short-lived and therefore does not stay in that form for a long time in your body. It degenerates. And therefore there's no fear for you having that messenger RNA, swooping around your body, forever. So that convinced me that I would take that. So that was from my lay perspective, the basis on which I made my decision.
Yes, I think you did you did it very, very well. I mean, you did understand exactly the message as it is meant to be. Okay. Now, Rogers, do you have one more thing before I come in? No, you are muted. Okay, Churchill, do you have maybe one more thing to say about the messenger RNA and the two types of vaccine?
Thank you. Let me just make a quick comment that the process of making a vaccine will vary, not just in COVID, but perhaps in any other condition that may benefit from vaccination. COVID has been understood in terms of its structure, in terms of its entry protein, which is the spike protein. It's like an arrow that has an ability, or a sword that has an ability to strike at a cell through an entry point in order to get into a cell. The receiver or the receptor for that particular spike protein is the angiotensin converting enzyme 2, which is like a cup that receives the virus using its spike protein. And the ACE2 receptors are distributed very widely, especially in the upper airways, especially in the lungs, but also in other tissues like in the kidneys, in the heart, in the brain, and wherever COVID can go. The idea of basically eliciting an immunity is to block entry of the virus COVID into the cells. Secondly, you may use a carrier, not a messenger RNA, which is another virus, an adenovirus. These are flu viruses that don't cause us a lot of harm. We feel sickish, but we are not terribly at risk of a serious illness that may take life or take us to intensive care. If you use an adenovirus, it is a vehicle for carrying a message to the cell so that the cell can prepare to block the entry point of COVID. Of course, antibodies may be produced that intends to neutralize various stages of viral replication. But remember that the purpose of a vaccine is to diminish the violence of the disease. Yes. It's not a cure. And I think the example given by our panelist, Dr. Alfred Banya, is instructive, because we don't know whether he would have basically had a more severe outcome. And I'm glad that he made it through. And so to diminish the violence of the infection or the disease is not necessarily to remove it or to cure it. From a public health point of view, you obviously want to reduce transmission and therefore protect the public, your next neighbor, from becoming infected. And therefore you want to minimize contagion from a pandemic point of view. And by getting vaccination, whether it's less than 100% protective, some form of immunity will make you less risky as far as outcome is concerned and contagion is concerned. I think that's the only part I would like to add.
Yeah, okay. So let me just come in just to give you just a layterm analogy, you see. Now, usually with the immune system, they are designed to protect you from what could be harmful. Now, what could be harmful is a lot of lessons. You have to learn what could be harmful. The unfortunate bit is that. So the immune system have to find a way of learning what is harmful and then use that lesson to eventually protect you from what they have learned before. So there must be a learning process for the immune system in order for them to protect you. Now, in order for you to learn about your enemy, you can use a lot of different ways of spying against your enemy. So you must have at least a scout or a messenger or something to inform you in advance about what that enemy may look like. Now, this is where a vaccine becomes important, because the vaccine is sort of a way of telling your body how the enemy may look like. Now, this is the challenge. If you actually bring a whole enemy into the body, that may be too dangerous. That was tried before. In fact, that's how we started almost with the smallpox and the rest of it. It's just giving the actual thing, but that killed. Then they realized that if you get a cousin of the enemy, then the body may learn a bit better. And that's why they got the one that normally affects cows, and they use it for the immune system to learn how. But that was during those days. Now with the DNA, or what has been the secret of life has been written there for almost any different type of life. We have now learned that, look, if you can get the secret coding of life of these enemies and then introduce that into the body so that the body is informed of that enemy, that could be a better way of doing it. Now, in order to do that, you must, first of all, decode that secret. And you must also learn which part of the enemy could be recognized better. It's almost like you are trying to teach your dog how to hunt an antelope, but without actually showing the antelope. So which part of the antelope is better to show the dog, so that next time the dog can recognize the antelope. And that's the main reason why we were then involved in trying to extract which part of the enemy, which is the virus, to educate our immune system using that. Now, the way of educating our immune system involves the fact that you have to, first of all, get the message from the virus to the body. And the only way you can do that is to use the genetic material we call messenger RNA. RNA simply represent ribonucleic acid, which is actually, it's just a chemical. It's almost like a sugar, a distorted sugar, you see? And that's why that is the one that you use. But that messenger RNA, by the way, does not do anything. It only shows the body what to make. That this is the secret of how to make this part of the virus. And that is what is then done. And then the protein is then made, but then the messenger itself is killed by the body after doing that. It doesn't stay there for a long time. But at least then the component of the virus, or maybe the head, or maybe the spike or something, is then that is replicated in the body. Then the immune system learn how to fight that part, so that next time the full virus comes, that part of the virus is disabled. It's very important for you to get the right part of the virus, and that's why we chose the spike. So this is the long-winded ways of trying to explain how the secret is done. You learn somebody's language, you translate it, then you go to and then teach other people that if you hear somebody who speak like this, he is your enemy. And that is almost like what the messenger RNA is doing. And it doesn't stay in the body for long.
Yeah.
No, one thing.
Yes, Professor.
Yes. Well, I'm told that one active ingredient in mRNA,
Yeah, messenger RNA, yeah.
yes, is polyethylene glycol, PEG, which has not been used in vaccines before. So one of the things that is stated is that its use in vaccines has the one element of uncertainty in that it's the long-term effect of PEG on the human body are yet to be uncovered. So nobody knows what it does yet in the long term.
Yes, it is a it's a sort of a solvent. You see, the thing is, if you make it in the old way, where you, I mean, where the message, because you have, as I told you, messenger RNA is a chemical. Okay. Yeah. Now you can dissolve it in water. I mean, your chemical, like your sugar, for example, to test it, you have to first dissolve it in water in order to test it. You see, so you have to dissolve it in something. Formerly, these messages were hidden in transporters, like the adenovirus, Churchill talked about. You see, so they are safe in there. You don't have to use anything. Now, this naked one, the naked one, now you have to find a way of finding of getting them into the human body, at least protected long enough, you see, for their effect. And that's the reason why they use those, the polyglycol. The polyglycol, of course, have not been injected directly into the tissues. But remember, the tissues also have ways and means where they normally can cope with those things. They are also simple molecules.
Yeah, actually, if I can add a bit there,
yeah.
The glycols are actually stabilizers.
Yeah, that's
allow the RNA, to continue being active.
Yeah.
And if they don't use it, it would degrade itself very, very quickly.
Immediately,
so this is the
they will be thrown away. Yeah.
Yes. So this is a kind of holding it until it is being used. Now the question is, how quickly can the body get rid of the stabilizer, which has made the vaccine active at the top point of delivery?
Okay.
Can I just...
So that's the only thing there. It's not an active point. It's not an active ingredient in the part of producing the antibodies. The messenger RNA to be available for it to last long enough to be given in the body. One of the things is these vaccines are really kept at very, very low temperatures.
Yeah.
And I think it just makes sense that if they were not cooled that much and we have the glycols to keep it stable, they wouldn't be able to use it at all.
No, they will not be.
Can I just encourage the participants, please, to check on the chat. There's a link to the survey. Please, I've got 11 respondents just now. It takes very short time. If need be, I can repost the link. Let me just see, I can just actually repost the link again.
Yeah. Yeah, you need more respondents.
There you are. So it won't take time. You can actually give us your response. Yeah.
Yeah.
Okay, you want one more question?
I mean, is the responder still there? The one who asked the question you asked? Because if he's there, then
Sure.
he could actually chat back to you whether he was whether we answered this question or not.
Okay.
Jasper, anything?
Yeah, this was asked by, I don't know whether I should say it. Yes.
No, by the respondent. I mean, by a participant. Okay, just say a participant.
Yes.
And if he's still if he's still around, or he or she is still around, since we could just try to answer to say whether we have answered it or not before we go to the next. I think we will answer maybe about 2 questions.
A short one here. Is it possible to have vaccine in a tablet form?
That would be the wrong route to have chosen, because that has been the most secure route for administering suspicious molecules like food. It will be destroyed almost immediately.
Exactly. Dead on arrival.
Yeah, it will. It's starting actually from the mouth. That's unfortunate. There are so many things to protect you against even poisons, you see. I mean, through your alimentary canal, that you can never throw a very delicate thing like vaccine through the alimentary canal. It will, unless you are protected it, like we protect certain medicine, you protect them so that they are only released at a certain part of the gut that they are needed.
Coated.
You see?
Yeah, precisely.
Yeah.
Okay.
Okay, Jasper, do we have another question? Maybe we'll answer that quite quickly before we.
Oh, this one, yeah, there's one, but let me see. Okay, how many Ugandans in diaspora have died of COVID-19? And what are you all doing to help our people back home receive COVID-19 vaccine, as well as raise awareness on how to reduce the risk of transmission?
Now, statistics. Anybody good with statistics? I mean, Rogers, you did a little bit of review, but I don't think we are covering. We are covering such kind of statistics at the moment.
No,
I think
if you see the number of deaths which are being reported recently in the
group
forums,
yeah,
and quite many who have died of the COVID. And if you think of the whole UK, there are people who are dying everywhere, but statistics is going to take quite a lot of time to actually gather and assign the cause of death appropriately. So that's a very, very difficult question.
Not now.
No. But we know that it's been the main source of death recently in the diaspora community.
Yes. And the second bit of the question is what we can do in order to.
Yeah, what are we doing to raise awareness? Yes.
Yeah. Yeah. This is part of the
this is one of the
thing we are doing now to raise the awareness, actually, is to hold this kind of thing. But we tend to work in good relationship with the Health Education England and Global Health, and we haven't discussed anything with them yet. But that is probably one of the routes we may take eventually to see what can be done to raise more awareness, particularly at home.
Yeah.
If I might add something else here, there are people who may have attended this conference today who haven't thought of questions to put forward. The link has been put up by James, and they can follow that. But we hope some of these questions can even come next month on the 13th, when we plan another Zoom conference. And it would not be out of place to bring forward questions that may have been not properly addressed today, so that people have got to keep that in mind.
Yeah, we have got a website as well. I mean, where we would
Yes.
prefer that they would ask questions. Yeah.
Right.
Okay, one more if there
Churchill,
is.
can you unmute yourself? Churchill, please.
I'm muted. I just wanted a quick suggestion that, you know, the job that you people are doing is great, but given the wealth of informations and misinformation, disinformation, one would need a think tank approach for the diaspora to filter information that can then be upgraded, updated, packaged, and disseminated in a suitable way for consumers at different levels. And I think it would be an ongoing task to keep update with what is going on so that myths are dispelled, new information is incorporated, and there's continuous update.
Fair point, Churchill, and that's the reason why we are really trying our level best to recruit. At the moment, we are very thin on the ground. We really appeal to the diaspora if they have got any, consideration at all to join DHSP, and our website is available. And I think James, you have done something about membership. Advancement, yeah.
There's a link down just in the chat right now that we can actually use. So yes, the link is there. Very simple. You go to website and just simply type join-DHCP and you'll get the form.
Yeah. Okay. Now, Jasper, there seems to be a question from United States. Marcelina, asking all the panelists, do you read what it is?
Okay, let me see. Is it there's two things going on. One is in the chat and one is the actual question and answers.
Yeah. Marcelina's question is, what is the non-impact of the vaccine on DNA? Worried about young people. That's what actually said.
Yeah. You see, that's the beauty of using mRNA messenger other than the DNA, you see? Okay. Because the messenger RNA is just like a note written on a piece of paper for somebody to read in order to do something. Okay? That note can then be torn away. And that's what the messenger RNA is like, okay? So it's not something that is going to do anything to the DNA. It is only something, an instruction of the cell that, look, I'm here, okay? Can you make this thing for me, okay? So it's a sort of short-circuiting.
Can I come in there? Yes. I think listening to this particular question, I'm mindful of some of the conspiracy theories where it says that you receive this vaccine, either one, it will change your genetic, composition or your children through the DNAs. And number two, you will have chips put in your system so that the government can track you everywhere.
No, but that's what Rogers discussed. That's what Rogers discussed. I think that has already been covered in Rogers' lectures, okay?
Yeah, but then the DNA part of it.
And has been dismissed, okay? But people should understand that messenger RNA does not affect DNA. In fact, it bypasses what the DNA is meant for, because that's the trick. That's the trick, okay? DNA is already been instructed to do the correct thing. So in order for you to deceive the cell to do what the DNA is not going to instruct you to do, is to give that cell a wrong message. You see, a message in the RNA. Then the cell will make that protein. You see, that's what the viruses do. You see, yeah. So the DNA itself is not affected at all. You see, it's like somebody coming in your house and saying your grandfather said you must do this. and you don't even ask for proof, then you start doing what that messenger is trying to tell you without any proof what your grandfather said. And that's what the messenger RNA is trying to do to the cell, not to the DNA.
Can I just chip in a little, Mr. Chair?
Yes, yes, Churchill.
It might not be as straightforward because maybe we don't fully understand, but messenger RNA is also the virus, is also the genetic material in HIV.
Yes.
It is an RNA virus. RNA ribonucleic acid is reverse transcribed in the human cell after entering the CD4 receptor. And that basically is how the virus unpackages its genetic material and embeds it in the DNA of the host cell. And it is through that transcription, reverse transcription, that the virus thrives. Is like a person coming into your house, breaking into your kitchen, basically hijacking your kitchen and cooking all the food that they like and eating it and getting out with lots and lots of stuff. And so there may be some genuine fear or non-genuine fear when the word RNA is mentioned, not necessarily messenger RNA. Messenger RNA is basically a protein manufacturer.
Yeah.
But RNA is a genetic material of the virus that can be transcribed, meaning the message can be swiped, if I use the word, into a DNA material. And there is some concern at some stage with viruses because of their rapidity of emergence of variants and so forth. And I think we need to be a bit careful that we may not know enough yet. Maybe new information will emerge, but we need to be on the lookout.
Yes, thank you, Churchill. Is it that the good thing with reverse transcription is that this is a special property for the immune cells, particularly the T cells and the rest of it. You see? Now, we don't know whether that can be done in the germ cells yet. And it has not been actually, it has not been demonstrated in the, so that people who are worried about fertility and the rest of it, that has never been described yet, reverse transcription in the germ cells. These are the ones that are going to then eventually become the sperms and the rest of it. And also reverse transcription is never been described in well-established non-proliferative cells, especially the differentiated cells already. Now, if one could have said that, okay, maybe reverse transcription could have been described in stem cells, that could probably be worrying. But that has not been. But this is a property for immune cells. Immune cells are supposed to do that because they are supposed to learn these invaders and deal with them. And even they themselves will then eventually be destroyed. And that's a problem with the HIV, because then even then the immune system is just completely being destroyed.
Yes.
Okay. One more.
What time do you have?
Well, we certainly we are 30 minutes.
But
we don't mind continuing since it is very lively.
Okay, I don't know whether we have finished all the work. So there are questions being asked anyway in the chat. So I think we are going to have quite a few questions to answer.
Yes.
Yeah.
One quick one. does vitamin D play some significance with COVID?
I'm surprised.
Churchill, I think I think you had one slide which showed that there's a study from my university, actually from Queen Mary, from my colleagues. It's actually in the very place I work, from William Harvey Institute. I saw that slide.
I'll give a very short brief, because while they set out with the notion that vitamin D in its active form might alter or modulate the immune system,
yes,
that particular study did not show any relevance of vitamin D deficiency or supplementation in COVID outcome. I think that's all I can say.
Yes.
But Churchill, while you're still there, could that have an impact in actually, when you look at diabetes? Where would vitamin D fit in with diabetes?
I'm not sure about the immune element in diabetes other than in type 1 diabetes. But in type 2 diabetes, you're talking insulin resistance, you're talking insulin hyperinsulinemia, you're talking chronic inflammation.
Yeah.
I don't believe that vitamin D has a well-substantiated role in the context of diabetes.
Mainly because it augments vascular endothelial dysfunction. I think that's what maybe that's what Charles is is aiming at.
But a whole series of drugs are available for modulating vascular endothelial abnormalities.
Yeah.
In fact, the platelet antagonists, starting with simple aspirin and maybe the so-called clopidogrel and so forth, may play a better role in those diabetics who have established cardiovascular risk factors.
Yeah. Okay. That's okay.
But Jasper, to answer your general question, vitamin D has important role in many body functions, and some of those body functions are actually very useful in with the immune system. Vitamin D does influence where the immune cells are being manufactured, bone marrows and the rest of it. It has got a lot of role and directives there. It has a lot of influence there.
Okay.
Yes, James, I think we conclude there.
Okay, can we say cheerio then? And thank you very much for attending this webinar. And we welcome you to our next webinar. We will advertise as usual. And please come and join us. And thank you for participating.
Yep. Thank you so much for the invite and for everyone's participation.
Thank you.
Thank you.
Cheerio.
Cheerio.
Bye.
Okay.
Bye.
James and Jasper, it is in your hands now.
Yeah.
Yes.
I'll just finish it just now.
Yeah, okay.
Thank you, everybody.